Okay, so we can start our session. So basically, we have 30 to 35 minutes for our panel, and probably this is the last session. So I'll try to conclude in the stipulated time. We are going to have few case-based discussions. Basically, we'll focus on target therapy in metastatic colorectal cancer. We'll predominantly discuss on monoclonal antibodies and target therapy in metastatic colorectal cancer settings. Are my slides visible?
Yes.
Okay, so here is the case one. Left-sided RAS and RAF wild-type metastatic colorectal cancer. We have a 67-year-old male with diabetes and hypertension, otherwise controlled. He was diagnosed with stage 2 colon cancer in September 2013. Sigmoid colon, operated, PT3N0 MSS, and was put on surveillance. There was DFS of almost 3.5 years. In March 2017, surveillance CT showed multiple liver mets. Basically, patient had mild abdominal pain, for which scan was done, and which showed multiple liver mets. And largest size was around 36 mm in segment 8 of liver. ECOG PS was good. So basically, I would like to start with Dr. Palak. How would you like to work up this patient, and how would you like to take things further in this patient? What are the things you would like to take in consideration for before starting therapy in this patient and deciding the intent of this patient?
Yes, I would like to obviously performance status of patient is very good, so we can start with chemotherapy with targeted in form of cetuximab or panitumumab, because KRAS and RAS is wild type. So first I would see the side of the disease, whether it is left-sided disease or right-sided, because cetuximab and panitumumab works better when disease is on left side. And then I will discuss with the patient all the possible treatment options.
Okay. So basically, final biomarker status report I will reveal in the next slides. But grossly, it is RAS and RAF wild type. So I'd like to come to Dr. Rajki. How would you perform molecular testing in this patient, and what is your practice? Usually you start something at baseline and then send molecular panel. Now you wait for the molecular panel report and then start it. Dr. Adi, are you there?
Hello, am I audible to sir?
You're audible, but your voice is very low.
Hello.
Yeah, please.
Sir, I will like to do all the molecular analysis by NGS panel. So I'll also like to do MSI testing and HER2 along with RAS and BRAF. And after that, I will like to initiate, if the reports are not available for molecular analysis, I may start with the FOLFOX. And then after the availability of reports, I may add the targeted therapy. If it is wild type, I may add the anti-EGFR. And also will consider the MSI testing for whether the option of immunotherapy is available or not.
Okay. Dr. Rushit, would you like to add anything?
Yes, I think I'll also go the same way. We'll send all the molecular markers upfront, including RAS, BRAF, MSI, and considering left-sided disease, and if all turns out to be wild type, then I would also add FOLFIRI with EGFR inhibitors.
Okay. What would be your intent in this patient?
Yes, that is also to be decided
Like
upfront, whether the all the liver metastatic lesions, the number of the lesions, and whether they're upfront resectable or not. Looking at the scans, if they might, it might not be upfront resectable, then we need to give, but potentially resectable. So we need to give conversion therapy, part of conversion therapy.
Basically, you would like to involve your oncosurgeon colleague and take a combined decision in tumor board, and then probably you would like to start the plan of action accordingly.
Yes, yes.
Okay, fair enough. Dr. Samir, any inputs from your side?
Hello.
Yeah.
Hello.
Dr. Sunil. Hi.
Audible.
Yeah, you are audible.
So this is. Can you just repeat the case scenario? CA colon with liver mets, I think, na?
Basically, yeah, baseline sigmoid colon operated 3.5 years back, PT3 N0, MSS at that time, EFS of 3.5 years, and now liver limited mets, and otherwise ECOG PS is very good.
Okay. So only liver limited mets means only liver mets. There is
Yeah.
no other sides, and
Yeah.
it is resectable, unresectable.
Not resectable at this point of time.
Not
Not
resectable.
resectable apparently. Yeah.
Okay. So even there is some data, Itesh, regarding liver directed therapies and even hepatic arterial infusion chemotherapy regarding downstaging and then getting converted into surgery. So even that point can be even discussed with intervention radiologists and surgeons. So that is one more thing other than systemic therapy.
Yeah, there are data for that. Agreed. But not we are doing that very commonly. But there are data for that. I agree with you. So what is your practice? What do you do in your clinical practice? If such patient turns to your OPD.
So I will, if it is for conversion therapy, then I would try to give whatever best possible regimen to have a maximum downstaging. So if it is a left-sided tumor and even if the patient is fit and it's all-RAS wild type, then maybe FOLFIRINOX plus panitumumab or cetuximab.
Okay, and
not more than
let's
4
say-
cycles. Not more than 4 cycles.
okay, let's say you told that everything patient is affording, you try to give the best possible regimen. Let's say we have a converse scenario, patient is not very affording. Patient say that I can't go for NGS. And what are the minimum molecular tests you would like to do in such patients? At least
Patient is not
bare
affording.
minimum.
So
Patient says, yeah,
RAS and BRAF.
RAS, RAF. Anything else you
RAS.
would like to do?
Then if patient is not affording, then there is no point in doing MSI and HER2.
Okay, okay.
Even RAS,
So
if
would your
patient is
plan
not
change?
affording,
Okay, we'll come to next.
even RAS doing, there is no point if the patient is not affording for cetuximab and panitumumab.
Okay. Yeah, but means they are borderline sort of. They're not affording for immunotherapy, but they can take some form of target therapy.
So I think then in such cases you can directly start with BEV plus chemo.
Fair enough. And if bare minimum you want to send, then RAS and RAF you would send.
RAS, RAF, yeah.
Okay. If you're starting your setup, then RAS, RAF is okay. That is fair enough. Agreed. Dr. Viraj?
Yes, Itesh.
Your expert comments on this? You have such patient coming to your OPD, your OPD in HCG, and patient is affording very well to do. You have discussed with your oncosurgeon colleague. You are planning for conversion therapy.
Yeah. So this patient looks borderline resectable.
Correct.
What we do in practice is HER2 MMR by IHC, which we get in 2 days, and then send off the samples. Both Merck and DRL both do RAS RAF free. So that's what I do. I rarely do NGS on day 1 unless patients ask for it.
Okay. So you do RAS, RAF, MSI, and HER2.
MMR and HER2.
Yeah, MMR. Okay. Great. Fair enough. So you get the reports efferently and you start after that.
Correct. So I always wait for a MMR. At our center, it is just 2 days.
Okay. Great. So these are the reports. RAS, RAF wild type. HER2 is negative. MSS. And probably you're planning for conversion. So
yeah.
starting,
So this patient again. I agree with one of the panelists of doing triplet plus anti-EGFR, but the case that you showed, I don't think so. The liver burden is so much. So in this case, I would stick to standard FOLFOX plus anti-EGFR.
FOLFOX plus and NDGFR you would like to start. And Dr. Tarachan, what would you like to start in this patient?
Yeah, Itesh, I agree that I will go with the cetuximab with the FOLFOX.
Okay.
And all the
Okay. So just a word from all the panelists. What would be your chemotherapy backbone, preferred chemotherapy backbone, and preferred anti-EGFR? Starting with Dr. Palak.
Chemotherapy, I would prefer FOLFOX with Cetuximab, and NGS panel refreshment is according as RAF
Okay.
and RAF.
Dr. Rajdeep,
Sir, Folfox plus Panitumumab.
Folfox plus P. Dr. Rushit,
Folfox plus cetuximab was connected.
okay. And Dr. Samir, triplet plus P you told, right?
Yeah, depending upon the situation, means how much downstaging you need.
Okay, fair enough. So I think we have vote of most of the panelists, and everyone agrees that we have to give at least a doublet, or in selected cases if disease burden is high and patient is very fit, we can go with triplet, and we can add NDG EGFR therapy to that. Fair enough. Okay, if in this case scenario, HER2 is +3 by IHC, then would your plan of action change? Starting with Dr. Rushit.
Sorry, Itesh, bhai, I missed your question.
So biomarker status of the patient, RAS and RAF wild type, MSS, and HER2 is +3 by IHC. More than 60% complete intense staining. I mean more than 50% of this, that is +3. So would your plan of action change in this patient? All other scenarios is same.
I think considering first line of treatment, I would not like to change my plan at present.
Okay. Dr. Rajdeep, your take on this?
So I will continue with the same plan because I will keep for the next line.
Dr. Pula?
Yes, sir. I will keep it for next time.
Dr. Viraj?
Yeah, so HER2 amplification confers resistance to anti-EGFR.
Exactly.
We have 2 papers, so we'll need to change the plan. Normally, these cases would go with BEV, or if at all we are converting or resection within 2 to 3 months, then just FOLFOXIRI, triplet chemo, no targeted therapy, but definitely not anti-EGFR.
Okay, so what is your take on recently published Cairo fight study in ESCO 2022? I think it says that triplet plus BEV is again good, but again it is more for RAS mutant patients rather than HER2 mutant. So I think 6 weeks of BEV and then you can go for conversion. It's okay. Means you can give that also. I agree with you. So point to be noted that when you are planning for NDGFR therapy, we should definitely get HER2 done, because HER2 positivity confers innate resistance to EGFR because it comes in the downstream signaling pathways of EGFR pathway. So better to avoid EGFR therapy if you are planning at all. And if you're planning with bevacizumab without molecular testing or with RASA, then it's okay. But if you are planning for anti-EGFR, then ideally we should go for HER2 testing. So it is 2 to 4% positivity, but definitely will change your plan of action completely. So take off panelists on the treatment sequencing. Starting with Dr. Viraj, do you think that treatment sequencing matters, whether you start with anti-EGFR and then you give VEGF inhibitors in second line or vice versa? Does it matter really for colon cancer? It depends on the side also.
So I assume you're asking for left-sided disease?
Yeah, sir, asking for both the sides, starting with in this patient and in general also. I'd like to have your comments.
So in left-sided disease, we have evidence now. Starting anti-EGFR first improves overall survival and leaving anti-VEGF for subsequent lines. While for the right-sided disease, very rarely have I used first-line anti-EGFR when I wanted to convert the disease badly. Otherwise, usually we go with BEV-based treatment in right-sided disease. Anti-EGFR, even in subsequent lines in right-sided, is a big question mark and a controversial issue. But better to give rather than leave them alone with regorafenib. So I typically keep for third line anti-EGFR for right-sided disease and for left-sided first line.
Except for conversion in right side, probably would like
Except
to do
for conversion. Yeah, that's what I have done. Yeah.
Agreed. Agreed. I also follow the same thing. So this is what Dr. Viraj said, that when we start in left-sided wild-type tumors, we start with anti-EGFR therapy and then we give VEGF in subsequent lines. Then median OS is more than 3 years. And if we give EGFR for in second line onwards, we lose 6 to 7 important months of median OS. And when we avoid EGFR totally, then median OS is hardly around 2 years. So, any specific choice between the two anti-EGFRs? Would like to start with Dr. Samir. What is your personal choice and why?
So I think panitumumab has less infusion reaction because it is humanized. Otherwise, skin reactions I think are more with panitumumab. Otherwise, from efficacy point of view, I don't think any difference is there. So then it comes to the cost, whichever is cheaper would be the first choice for me.
So what is in your practice? Say you give anti-EGFR to 10 patients. Out of 10, how many patients would receive cetuximab and how many would receive PMAB?
50-50, I would say. So difficult question.
Okay. Okay. Fair enough. Dr. Palak?
I have more experience with cetuximab, actually, because we generally
Giving cetuximab, I would prefer it, but I don't think there is direct comparison between two agents for the point of view of efficacy or anything. So anything would be better, but I will prefer cetuximab more.
Dr. Tarachan, your take on this?
Itesh, actually, I use only the cetuximab, no panitumumab till now. Any patient. Actually, as we know that as per the trials, there is no head-to-head comparison, but both are the same with the same results. So I am sticking to one molecule only, and since my oncology journey only, and even I'm more towards because I am having a head and neck patient more than, so I'm using in their cetuximab. There is no role of panitumumab, so I usually don't keep in mind that panitumumab is there or not.
Absolutely. So it's we have seen that it is a choice of the treating oncologist, their own personal treatment preferences. But either ways, you can give any of the maps. There is no head-to-head comparison. But if we see the data, then there are slightly more skin reactions with PMAB and more AEs with PMAB, while more infusion reactions with cetuximab. Otherwise, from efficacy point of view, there is no significant difference. And if we see from clinical phase 3 data point of view, recently there was a paradigm study in which Folfox with PMAB was compared with Folfox with bevacizumab in wild type RAS metastatic colorectal cancer. And in this, we have recent now a phase 3 data. It shows that in left side population as well as in overall population, PMAB fares better as compared to bevacizumab plus Folfox based doublet. So with this phase 3 data was lacking, but now in ESCO 2022, from this we have that data also. But still, many of us do prefer cetuximab because we have used it more commonly, and we are also using it quite commonly in head and neck setting. So these are the differences. Like cetuximab activates innate immunity more as compared to PMAB, and other points are already discussed. We have already discussed the chemotherapy backbone. And as Dr. Viraj pointed very well, that triplet chemotherapy with anti-EGFR is what when we are looking for conversion. Even in further selected right-sided tumors, which are wild type, RAS, RAF, and HER2 are negative, we can go for a triplet with anti-EGFR, and we are planning for conversion, not in palliative settings. So coming back to a patient was planned for doublet with cetuximab. At 2 months, there was a good tumor shrinkage and more than PR response. Patient underwent surgery, pectotomy and metastaectomy, and completed 6 months of a total 6 months of perioperative chemotherapy. Therapy was stopped in December 2017. Again, after 1 year, there were multiple lung mets.
Itesh,
Yes.
just 1 minute. I think there was just I think recent data published. I think discussed in ESMO also. So there is no role of giving adjuvant therapy in a resected liver met in a colorectal cancer. There is no OS benefit, just a small PFS benefit. I think you people can also comment on that. I think is there a role of any then in such cases giving adjuvant therapy if the tumor is already resected?
You have given a neoadjuvant therapy. You have converted this patient. Then
Yeah, that's fine. That's your work is done now. Is the adjuvant therapy is going to benefit that patient?
I'm not aware of this data. So this was all again in December 2017, And again, in my practice, I give 6 months of perioperative therapy to all those patients, those who I have given neoadjuvant therapy. But I would like to have a comment from other panelists also. Dr. Rushit, what is your practice in such patients?
I do complete 6 months of chemotherapy and we omit the targeted therapy.
Dr. Viraj?
Yes, so the paper that we are alluding to was a resectable liver metastasis. This patient had unresectable disease, different biology. So I agree, I would finish the 6 months of chemo while omitting the target therapy after operation.
Okay. Again, it is not very clear cut. We don't have very strong phase 3 data to support this. But still, what have we been practicing that we try to complete 6 months of at least chemotherapy in such patients, because ultimately it is a systemic disease. It is angiogenic disease. So we need to.
Itesh, if it was upfront resectable, then what would be the plan for all the oncologists in panel?
Point well made. We start with Dr. Palak.
Then I would prefer only chemotherapy, because if it is upfront resectable, then I would prefer to give cetuximab or target subsequently.
Dr. Rajdeep, he's asking, would you like to give any systemic therapy or not? I think that is what Dr. Samir is asking, right?
Yes, I would like to give systemic therapy.
Okay.
If it is metastatic and liver mets is also resectable, then I would like to give.
Okay, Dr. Rajdeep.
Yes, sir. I will like to give 6 months of total perioperative chemotherapy only.
Okay, Dr. Viraj, definitely operable.
Yes.
Resectable
So,
disease.
yeah, so this is the most debatable topic, right?
Again, agreed.
So I'll give you two scenarios where one should do perioperative and one should not. A 75-year-old patient had a sigmoid colon 3 years back, now comes with one liver met. I agree, liver resection and leave him alone. 46-year-old with 3 liver mets, right-sided disease, KRAS mutant, CEA 4000. I think so. I would do perioperative, even though surgeon says resectable. So I forgot the name of this criteria, but there is this criteria of 5 points where you have de novo disease, a lymph node around your primary CEA, size of the liver met. So these are all important components, not only your surgeon telling you that I can take it out.
Right. And these are all metachronous disease, right? That is what.
Correct. So depends, right? Metachronous versus synchronous.
In synchronous, so you are going to give at 20 in any case, right?
Well,
Yeah,
so
right.
let's say, so I'll tell you, right? A left-sided sigmoid disease with a solitary segment 7 liver lesion of 1 centimeter in a 75-year-old. I have seen, and this is exactly what doctor was referring to. There is no OS advantage of giving adjuvant chemo in this patient.
Yeah. And you see the primary stage also again. Agreed. Okay. I think we have only some time left. We are running short of time. So I think we will take the discussion further. So the conclusion is most of us would like to give 6 months perioperative therapy if it is apparently unresectable disease. For resectable disease, you need to take call on an individual basis. So this patient has again lung mets after DFS of 1 year. So just two comments from panelists I would like to have, that would you like to do any molecular testing at this point of time, and what would be your further plan of action in this patient? Starting with Dr. Palak.
So now disease recurs, so we have to go start with subsequent line of treatment. I would not like to do again biopsy and do NGS or anything else.
Dr. Samir.
Hello.
Dr. Samir.
So now same patient has progressed
After 1 year. Lung
1 year with
mets.
multiple lung mets.
Multiple
So
lung
that
mets.
patient is off therapy since how many? 1 year, 1.5 years?
Since 1 year. December 17 to December 18.
And last time he received, I think, FOLFIRI, not FOLFOX.
Yeah, full ferry. And 2 months of pre-op cetuximab.
So I think you can just change the chemo backbone FOLFOX and you can again start with anti-EGFR target therapy.
Agreed. And any role of molecular testing at this point of time?
Generally, these are like driver mutations, which are like doesn't change generally with, but definitely there are few data in few patients it may change. So there is no harm in doing that, I think. But generally, I don't repeat.
Liquid biopsy?
That is for same thing, na, for seeing the change in the mutation status.
Yeah.
Ideally, you should do if patient is affording and there is no cost issue, you can repeat.
Dr. Viraj?
Yes,
Your
so
take on
if
this?
one is considering using anti-EGFR again, then I would
Agree.
definitely do liquid biopsy. It's available in 15,000 in India. I don't think so it's a
Yes.
cost issue anymore. But the point is whether you do use anti-EGFR again, or would you keep it in the third line or fourth line? I would do BEV-based treatment in this case.
Agreed. Fair enough. I would also like to do BEV based treatment in this patient. And this patient was given bevacizumab with chemotherapy, a full FOX plus BEV. After 4 cycles, the disease was stable, and oxaliplatin was discontinued. So patient was continued with 5FU plus BEV. I just like to run fast. We have just 5 minutes left. And so basically, after total 8 months of therapy, patient again progressed multiple liver and pulmonary lesions. So all the panelists, would you like to, patient is fit PS1, starting with Dr. Samir followed by Dr. Karachan. What would be your third line of treatment in this case?
I think we can go with all the options are correct except the immunotherapy for me in these cases, because after on the progression we can continue all those the bevacizumab. I don't remember the trial also in the second after the progression also. And second, that we have given in the cetuximab till 2017 only, and then bevacizumab. So we can add a cetuximab now with the chemotherapy also. That is also showing, because at that time it was a good PFS with the cetuximab, and now it is already almost around 2 years have gone.
Right.
And panitumumab, yes, I am not using, and regorafenib is also an option because it is a standard third line therapy. So it is a choice of matter. If it comes to me, then I will go with cetuximab plus chemotherapy.
Agreed. Okay, fair enough. So basically, we can re-challenge, and as point made by Dr. Viraj, we should ideally go for liquid biopsy and confirm EGFR status and RAS and RAF status. RAS and RAF status before starting anti-EGFR. There is a phase 2.
So, how many times the RAF status change?
So there is a data, because this is basically these are the driver mutations. So there is a, I don't know exact percentage, but probably I read somewhere in some article it was around 15 to 20% if I'm not wrong. Dr. Viraj?
Yes. Yeah, 1 out of 4.
Yeah,
1 out
almost
of 4,
15 to 20%.
you will find
it might change.
RAS mutant clones in the liquid, and usually that will confer resistance to your subsequent anti-EGFR. So if you are planning to use anti-EGFR third line or fourth line, I would definitely do a liquid biopsy, at least for RAS. If
for
not
RAS.
for, yes.
Yeah, agreed. So if patient is going for,
Itesh, I agree, yes, that. But my concept is that yes, theoretically you can do liquid biopsy or re-biopsy or liquid biopsy, whatever you do with the NGS. But the disease was already stage 4 metastatic at the time, and we finished the treatment. And yes, we gave the pseudo adjuvant at that time also. So this is what I think, that this is the same disease which has progressed. And I don't think that in my practice, I will not do the repeat biopsy at the same time. Yes, if it will happen around 4 or 5 years or a quite bigger time, then 3, 4 years or 5 years, then I may do a re-biopsy. Otherwise, not.
So we don't do tissue biopsy. It's basically liquid biopsy.
Liquid biopsy.
So what happens is, if any patient who was wild type and has undergone anti-EGFR based treatment, that patient has an innate ability to mutate, and that typically shows in form of RAS mutations or some other resistant mechanisms, which we have shown with 2 main trials, Kronos and the cricket, what Itesh just showed last slide, that
Right.
you will have 0% response, absolutely 0. So
Yes.
if you are planning to again spend 1 lakh every 2 weeks, it's better to do a liquid biopsy.
So basically, it can be means a patient may be having two clones, and the wild type clone has got suppressed, and the mutated clone is coming up. That may be also one of the
Correct.
explanations.
That is
Yes, yes.
explanation. Absolutely.
It is the explanation for that. Okay. So basically, in
But
third line,
Itesh, but why you people chose BEV plus FOLFOX second line rather than re-challenging with the EGFR target therapy? Any specific reason for that? You and Dr. Viraj said you will go ahead with FOLFOX and BEV. Why not to re-challenge that time only with cetuximab or panitumumab?
re-challenging again is a good option. It is not a bad option, but again, you see, when we think of re-challenging these clones with anti-EGFR therapy, you have to have some gap. So in between, basically the new clones have evolved which are resistant to cetuximab. That is what is thought. So in second line, you give a cetuximab-free interval, you give more time to the patient, you give anti-VEGF therapy, and in third line again you can re-challenge, provided RAS is wild type.
So just a logic to keep maximum duration of cetuximab.
Yeah, in generally, but in this case we have not given an adjuvant cetuximab, so that is also a fair option. Re-challenging cetuximab in second line is also a fair option according to me. But in generally,
definitely after liquid biopsy.
After liquid biopsy, without it.
Okay. Thanks.
So I think we have only 2 minutes left. We'll skip this second case. I will just like to have comments from all the panelists regarding patients with HER2 positive. We know that all the paradigm of molecular targeted therapies in colon cancer, the evolving is HER2 over amplified or HER2 over expressed metastatic colorectal cancer. So just to highlight diagnostic criteria, if anyone can comment, Dr. Viraj, for HER2 positive in colorectal cancer, Paracelsus criteria.
So what we do in practice is IHC, the gastric version of IHC, not the breast version. Okay. And if we are doing NGS, then you see the copy numbers of ERBB2 gene. If they are more than 6, then that usually again confers resistance to anti-EGFR.
Okay. Dr. Rushit, how do you test for HER2 in metastatic colorectal cancer? Any comments from your side?
Yes, I also test by HER2 by IHC for breast only. So not specific different clone.
Okay, so just to make a point, Heracles diagnostic criteria and Heracles trial used HER2 plus 3 as more than 50% of the cells with intense membrane staining plus 3, or if by FISH again HER2 by 17 ratio more than equal to 2. Any of these two is required to stamp as HER2 plus 3. When less than 10 to 50% of the cells are positive in IHC, then you have to go by reflex FISH testing. So this is a point to be kept in mind, that it is not exactly same as breast. HER2 testing is different in colorectal cancers, and many cases are over amplified rather than just overexpressed. So just a quick comment: when would you like to add HER2 targeted therapy in which line, and you would like to add a singlet or a doublet HER2 blocker? Quick comment from all the panelists, starting with Dr. Pollack. RAS, RAF, wild type, MSS, and HER2 over-amplified or overexpressed left-sided colorectal cancer, metastatic.
So now we know that if HER2 is overexpressed, then role of anti-EGFR is very less. So we can add upfront, or just we can go for chemotherapy plus bevacizumab at time. Subsequent line we can add HER2 if not used in first line.
And what is your HER2 anti-HER2 therapy of choice in second line?
Trastuzumab. Yes, there is a Trastu plus HER2 as well. But
okay, if patient is affording, cost is no bar, then
definitely. Then combination therapy.
Dr. Rajdeep.
Sir, I will like to use combination therapy, trastuzumab plus pertuzumab.
From which line?
Sir, from third line onwards.
From third line onwards. Dr. Rushit?
Yes, it is based. So from second line onwards, we can add dual anti-HER2 if possible.
Okay. Dr. Samir, Dr. Tarajan, and finally Dr. Viraj, before concluding.
So I think TDX is the best, I think, here. if
Yes.
if we can get it available.
Yeah, absolutely. TDXD is a wonder drug for HER2 positive patients. And for HER2 plus 3, data was excellent. HER2 low, again, data is not that good in colon. That is what I could conclude from the recent paper. Dr. Tarachand and Dr. Viraj, if you would like to add anything.
For HER2 positive, actually, it is, I did not see any patient till now because in my practice, GI patients are very low. So number of GI patients. So I have not come to the HER2. But yes, if the patients come to me and HER2, I will not use in first line. But yes, in second line, I can go with the TDM.
Dr. Viraj, any additional comment from your side?
So, single agent HER2, we have enough data to suggest it has absolutely no role. We have to use dual anti-HER2, whether you use it with TKI or you use 2 antibodies, it's up to you. The current best is Mountaineer with tucatinib. The Destiny, although showed improved OS, that 10% increased risk of ILD, I don't think so is feasible.
ILD is
It's too toxic drug.
Problem with TDXD. I agree, but tucatinib and irotinib have also shown very good results. So just to conclude, HER2 is generally a negative predictive marker for anti-EGFR therapy, and these patients have more predilection for meds in lung as well as brain because of HER2 tropism. They have trend towards poor prognosis, and HER2 targeted therapy can be added from second line onwards, preferably dual HER2 targeted therapy. I think I would rest my case here. Thank you all the panelists for a wonderful discussion. Have a good night. Thank you, Dr. Garambi. Welcome to the back to the organization.